This used to be a very rare disease that oncologists really hardly saw, but the incidence has been increasing, and so I think we're seeing more and more of it. I think we're just identifying it better. I think what's been great in the field of neuroendocrine tumors is this was a disease where we had no options for quite a while. We would basically tell patients, we're going to watch you if they had a slow-growing disease, and that was uncomfortable for patients and for oncologists. What's happened in this field is that there's really been a boom over the last few years, where we've gone from somatostatin analogs to now we have PRRT, which is peptide receptor radionuclide therapy, which is really an effective therapy that has finally been approved in the US for the treatment of these patients. On top of that, in between, we've had clinical trials that have shown us that targeted therapies, mTOR inhibitors, VEGF inhibitors, also have demonstrated activity in this disease. So suddenly, we have several treatment options. This was a disease that used to primarily be treated by surgeons, interventional radiologists, because we were doing local regional therapy, blading, and what have you. But now we have several options. I don't think we know clearly how to sequence these options now, but we've gone from a disease where there was really nothing in my career to now where we have lots of options and we have effective options for these patients. And what's great about this disease is if you do have well-differentiated, low-grade disease, these patients live a very long time. So they're going to probably go through multiple lines of treatment. And so I think that's where we actually need to figure out, how do we best sequence these therapeutics so that we're not harming individuals so they can get to the next line if they need it in the future.